Good afternoon. I'm very excited to be here because I am fairly new to the field of population health improvement, but having been here since this morning, I see so many areas of intersection with the work I've been doing on Pay for Success, and I hope you do too. So just to start out, how many people here are familiar with Pay for Success financing, also called social impact bonds? Okay, a lot. So pay for, okay. Well, I think what I'll do is three things. One is I will give a refresher on what it is, but I'll try to do that fairly quickly, and I'll talk about where the field is. And then third, I'll hopefully spend most of the time going through an example of how it can be applied to improve population health. And that's based on a study I did in South Carolina. So this is not a new idea at all. And David reminded us in his introduction of his 1997 publication, Paying for Results. So why are we talking about it now? And this is what I will posit to you as the reason. Two trends and one problem came together to get everybody to focus on this new financing mechanism right now. One trend is impact investing. And around the end of 2010, JP Morgan and the Rockefeller Foundation came out with a report called Impact Investments in Emerging Asset Class. And in that report, they placed a dollar value on the amount of money in impact investment that would be available over the next 10 years. And this is investment that aims to achieve social results as well as financial results. And the number was $400 billion to $1 trillion. And that got people's attention. Second trend is the interest in measuring impact, and that's the foundations here are seeing that and leading that movement, and governments are moving in that direction, and service providers are also moving in that direction. And then the problem is the problem we've been talking about all day, which is that government is spending a lot of money reacting to problems after they've happened, like prisons and hospitals and special education and foster care. And these take so many resources that, especially in times when government budgets are tight, there's not much money to spend on the programs that we know can prevent those problems from happening in the first place. So Pay for Success financing was designed to address that problem. And just a note on terminology. So I'm entitling this Pay for Success financing, but I will go back and forth with the term social impact bonds. The term was initially social impact bonds. It started in the UK in 2011, but in the US, we've largely made a shift to the Pay for Success terminology for two reasons. One is they're not really bonds, and so that's just confusing to people. And the second is that this is the neat thing about this idea is that it applies to across the political spectrum. And so some people weren't too enamored of using the word social. So we've moved toward Pay for Success, but you'll see me use both of them. So this is how it works. Investors put money up front to implement cost-effective programs on a large scale. Then government contracts to pay back the investors with a small premium after the programs have demonstrated that they achieve some predetermined outcomes. And there may be an intermediary that manages the project that contracts with the investors and with the government and contracts with service providers to implement the interventions. And an impartial evaluator determines whether the outcomes are achieved by using a kind of accepted research evaluation methodology and comparing them to some kind of a matched comparison or control group. And I'll give you an example in a second, but this can benefit all the different parties, and you can read that yourselves, but I think people talk about this a lot as a win-win-win or a win-win-win-win. Everybody likes the idea, and it seems that it will work for everyone. So I'll just give you a concrete example by talking about the first one in the United States, which was in New York City, and I was involved in some of the planning of this project. And this was just launched in 2012. So before this project, about 50% of the teenagers released from jail were back in jail within 1 year. And so the city wanted more of these young people to succeed and fewer of them to come back to jail. And it looked at interventions that might help accomplish this. And it reviewed the research, and you probably won't be surprised, found a cognitive behavioral therapy intervention that had worked with a population like this, and proposed this social impact bond to scale it or to implement it. And so this project, actually they called it a social impact bond, so that's why I'm using that term, funds implementation of this cognitive behavioral intervention in the jail for about 3,000 young people passing through the jail every year. The investor is Goldman Sachs. Goldman Sachs invested $9.6 million through a 6-year loan to an intermediary, which is the nonprofit MDRC. And that's basically funding 4 years of intervention at $2.4 million per year. And the outcomes are going to be determined by comparing the results of those cohorts to those of a matched comparison group. And the outcome metric that determines how much payment will be made is not just whether the young people return to jail, but the number of days they spend in jail upon return. This is because that's tied to cost, because the city's correction system is paying to house these young people in jail, and the longer they stay, the more bed days that occupies, probably a familiar concept for those in the hospital world, and the more money they'll save if they avoid that. And so this is the actual payment terms. And you will see that at the top, Goldman could get 11.7 million on its 9.6 million investment. If there's a 10% reduction in recidivism bed days, then they get their principal back but no return. And if it's less than 8.5% reduction, the investor gets not only no return, but loses the entire investment. So that's a decent return on the upside, but not enough to compensate for the risk of losing everything. And so conveniently, New York City's then mayor, Mike Bloomberg, was a billionaire and had his own foundation and was able to provide a $7.2 million loan guarantee to guarantee the investment by Goldman Sachs. So actually the most that Goldman can lose is 2.4 million. So just any questions on this before I move on? Okay, great. And just one more terminology issue is I want to distinguish this from pay for performance, which I think is a terminology in the health field. And in the kind of social service field, we would call it performance-based contracting. And it's related, but it is different because pay for success focuses on the outcomes and not on the process measures or outputs. So pay for success wouldn't compensate on the basis of, say, percent of patients who get a specific type of screening. It would look at the percent that actually get the disease or end up in the hospital. And having worked in the criminal justice field for quite a while, I had worked on performance-based contracts for exactly this type of program, but they were paying us for whether the program was engaged with the people for 90 days, whether they were referred, whether they attended a program. even though it was aiming to reduce recidivism, we didn't even know what the recidivism rate was of our program or of the baseline that we were trying to beat. So that's the innovation here, is it's really paying for the results. So now the state of the field. It's still very new. There are only 9 completed deals in the world. Some people quibble with that exact number, but and that includes 4 in the US. And actually Rob Duggar, who you'll hear from in a minute, it was one of the major drivers behind the second deal in Utah after the New York City one. And we don't have results from any of them yet. The first one in Peterborough in the UK was also a recidivism reduction project. And they've put out 2 interim reports on the outcomes, and they look like they're going in the right direction. But unfortunately, the interim reports don't report the results as compared to the actual comparison group that will be used for payment in the end. So we're not entirely sure, but that will come out, I think, later this year. So now in the health field, health seems like, and population health specifically, seems like a good candidate for this type of financing, because there is a strong evidence base for at least some of the interventions, and the benefits far exceed the costs, and they save money. But there have not been any completed pay-for-success transactions that focus on health outcomes yet. Rick will talk about a project, a very exciting project that is headed in that direction, I believe, around asthma prevention. But I think that actually the farthest along may be the project that I worked on in South Carolina. So I'll give you a short summary of that as an example, and then I can see what questions you have. So I conducted this feasibility study for an organization called the Institute for Child Success based in South Carolina. And interestingly, it was funded half by the Duke Endowment and half by South Carolina's Medicaid office. And the study was to look at the feasibility of this type of financing to scale up the nurse-family partnership, which many of you may be familiar with, as a way of improving outcomes for young children in South Carolina. And that study, conducted that from January till August of last year, and it formed the basis for a request for information and a procurement process that the state of South Carolina is now in the middle of to actually complete one of these transactions to improve maternal and child health outcomes. So it's still in process, and hopefully it will come together. But what I'll show you is the feasibility study that kind of gave people the courage to move forward because they thought it might actually be feasible. So, okay. South Carolina is ranked 45th in overall child well-being. This is according to Kids Count by Annie Casey. And so they have a lot of reason to try to improve health outcomes. And as you probably know, there are interventions that improve outcomes for children and that have a strong evidence base behind them. And one example is home visiting programs. So these are programs where trained professionals provide services and support to pregnant mothers and parents with young children, primarily during visits to the family's homes. And there's a lot of research showing that these programs can significantly improve outcomes for both the mothers and the children. And South Carolina has actually implemented many of these programs. There's federal funding to implement home visiting programs in many parts of the country, but they're not at a scale that's sufficient to move the overall numbers and to make a big enough impact for the state. So there's several home visiting programs out there. We focused on the nurse-family partnership in part because of the evidence base behind it. And in that intervention, registered nurses actually visit pregnant women and during their second or third trimester until their child is 2 years old. So first we looked at the target population for this intervention, and we found that 11,500 very poor women give birth to their first child in South Carolina each year, and that's the high-risk population that Nurse Family Partnership targets. But in 2012, the program, even though it had recently expanded, was only able to serve 568 new families. So most families were not getting this program. So we looked at the data and the capacity and worked with the providers on the ground and came up with a proposed expansion strategy. And we did it by looking at specific counties and the eligible population and the capacity to expand, and we assumed a 25% penetration rate. And we determined that that basically the Nurse Family Partnership could realistically expand to serve about 2,750 new families per year. And then we looked at their cost data. And they have a per family number that's pretty good and has been adjusted for South Carolina. And so we found that to expand Nurse Family Partnership that much, it would cost about $21 million. And based on some analyses of both cost benefit, but also savings to various government agencies that can be generated based on the outcomes, we projected it would save about $52 million. So the net savings would be about $30 million over time. And about 2/3 of those savings would come from Medicaid. So that's about $5 in savings for every $2 invested, which makes a pretty attractive investment opportunity. Now, these savings come from a whole range of outcomes because these early childhood interventions have impacts in child maltreatment, in education, in criminal justice, as well as in health. But to do one of these contracts, as you saw from the New York City example, you really need a specific metric on which to condition payment. And so that was one of the challenges we faced, and we decided to focus specifically on the health outcomes for two reasons. One reason is that that's what the state was interested in. I told you that it was partially funded by the state Medicaid office. They were keenly aware that they had terrible birth outcomes and had an initiative already underway to improve them. And so that made sense to focus on the health outcomes. And the other reason was that they had relatively good data on health outcomes because of all the Medicaid data. And then also we focused on outcomes that happen fairly quickly in the first 2 years of life. Oops, not yet. So we put this all together and figured out that you could make it work. You could have the Nurse Family Partnership ramp up to serve 2,750 new families phased in over 3 years. The state would choose 1 or 2 health outcomes, and it would pay only if there were improvements in those health outcomes as compared to a control group or a matched comparison group. And it would cost about $21 million to do that, and the state would have to pay, you have to pay for the evaluation, the intermediary, and some return on the investment, so maybe it would cost the state in the area of $30 million to pay for the outcomes. So we ran these numbers on preterm birth numbers specifically. And we looked for these are not, that's only that county, but we looked at all of the counties that would be included in the site if the Nurse Family Partnership were expanded, and looked at their preterm birth rates and then looked at the research to see what the nurse-family partnership does in terms of reducing those rates, and came up with some projections of how preterm birth rates could be reduced. So next was the question of, well, could you make the financing work? And so we ran that scenario by the two major intermediary agencies or intermediary organizations in this area. There's one organization called Social Finance US and one called Third Sector Capital Partners that exists solely to promote and serve as intermediaries in these pay for success transactions. And so we showed them these numbers, and between the two of them, they came up with, I think, 3 potential financing scenarios that would mix commercial and philanthropic capital, and also ran it by some other more business savvy people who also felt that that was feasible. So that was enough for us to conclude that this was feasible. And we reviewed it with government officials and providers and potential investors in South Carolina, and got an enthusiastic response. So now we're hoping that it will, the details would need to be worked out for a specific transaction, but we're hoping that the result will be shifting of investment toward the effective preventive program and better outcomes for children. So I have a couple concluding observations, but before that, any questions about this South Carolina study or how it would work in yeah.
Who's conducting the evaluation?
That has not been determined yet. That hasn't been determined in South Carolina yet because the deal is just being put together. In New York City, it is the Vera Institute of Justice, a nonprofit, and ideally you would have the evaluation and the intermediary funded by the investors as part of the cost of the deal, and they would get a return. In the New York City one, it's actually being funded separately. Yeah.
So you say you're looking at reductions in low birth weight to find the savings, and I don't mean to say that it's bad to visit people for 2 years after the baby's born, but you're not going to get the savings that the place where you're looking for the savings is really in the decrease in the low birth weight. Is that correct?
Well, we ran this on preterm birth. So yes, right. That happens before the 2 years.
Right. Okay.
Yeah,
I just wanted to clarify, because then there could be certainly more savings. This is a conservative estimate.
Yeah, well, but you point out a really important challenge, which is that those savings from the preterm births alone do not cover the cost of the program. And there has been a lot of discussion in the field of how do you deal with outcomes that happen later over time and maybe in different systems with different funding sources, federal, state. And the way this question didn't come up in the first couple transactions because in the criminal justice system, you're looking at prison, there's one payer and it's easy to measure and you don't confront that. So the way we dealt with it in our feasibility study was we acknowledged that it didn't in itself pay for the entire program, but number one, it was important to the state. And we felt that even if it didn't necessarily pay for itself during the time of the investment, it still would be paying for success and worth paying for. But secondly, it's also a bellwether for future outcomes. And I think that the Institute of Medicine has put together a consensus report on all of the further down the road costs of preterm birth. And so we felt like that was kind of a fair bellwether for a whole bunch of other long-term problems. Okay, anything else? Great. So I want to say that there are challenges to this financing mechanism. That was one of them. There are others as well. But the reason that I'm excited about it is that it gets multiple sectors together to focus on and be accountable for outcomes, which is something that I've heard come up several times today. And also, it's a way to shift to actually, it's a mechanism to operationalize that shift of funding from remediation to farther upstream. And I think this is this moment that we have right now of extreme excitement, and some would say hype, about this new kind of financing really presents an opportunity. And we need to seize that opportunity to try to achieve the outcomes that everybody's been working toward for quite a long time.
Megan, great overview. Megan's going to join the panelists, so we're going to hold off on questions till then. We're going to take a break now and be back promptly at 3 o'clock for the panel discussion. So a break till 3. Thank you.